This meeting is being recorded.
Good afternoon, everyone who's joining us today. My name's Angus McFarland from the Australian Services Union, and we've got a great session this afternoon with some excellent speakers and experts to answer some questions that we are commonly getting to help our members right now working in the front line of community and disability sector in New South Wales during this current Omicron sort of surge that we're experiencing in our community. We have several hundred registrations today, which is excellent. So I will give it a couple of minutes just for others to join so they don't miss out on anything, but then we will kick off. And as promised, as advertised, we will finish absolutely by 3, no later than that. So everyone's aware, and we'll hope to get to as many of your questions as we can by then. Okay, we're still welcoming a lot of people into the room. It'd be fantastic if you want to introduce yourself in the chat box, your name, the service you work for, or where you're joining us today across New South Wales. I'm the acting secretary of the ASU, and so I'm in Redfern on Gadigal land in our offices here. But I know we have people joining us from diverse services across many regions in the state today. So do feel free while we wait to introduce yourself in the chat box. I also should say this is a webinar, and we will have opportunities to answer some of your questions throughout the discussion. And the best way to put those questions would be through the Q&A function. So the chat can sometimes be difficult to follow, but the Q&A is the best place to put your questions. And feel free to pop some in right now. We've got people monitoring that, and we'll make sure to get to them during the session. So if you've got burning questions already, put them in there now, and we'll certainly make sure we can get to them. But obviously you might come up with some things prompted by the discussion, and we can then take them as we go throughout the session. Still clicking over with more people joining, but I'm conscious of wanting to get underway so we can hear from our wonderful speakers today. So I might just kick off and formally open this webinar. So again, for those of you who have just joined us, my name is Angus McFarland, and I'm the Acting Secretary of the Australian Services Union in New South Wales and the ACT. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay respects to elders past and present. As I said, I'm on Gadigal land in Redfern today, but I know we have people from across all the diverse lands of our state. So this is the third of our webinars that we've held for our members working in frontline community and disability services over summer. We started at the beginning of January with information around sort of leave entitlements and industrial questions that we were getting from members as the virus was spreading and more people were getting sick or having to isolate. We then had some webinars last week looking at the risk assessment process and continuity of service plans and reviewing them in light of the current Omicron outbreak. And today's webinar is sort of an extension of those two, but this time with some excellent guest speakers to go into a bit more detail, I guess, around what supports are there for our industry and workers at the moment. What is some of the latest advice, especially on PPE, which we're getting a lot of questions about, and to take your questions to the best of their ability. So we have 3 fabulous speakers joining us. We have Melissa Clements, who's the Deputy Registrar of the NDIS Quality and Safeguards Commission. Hi, Melissa. Thanks for joining us today.
Hi.
We also have Sophie Holloway, Director of Policy and Practice Partnerships at the New South Wales Department of Communities and Justice. Hello, Sophie.
Hi everyone.
And we have Kathy Dempsey, who is the New South Wales Chief Infection Control Practitioner from the New South Wales Health Clinical Excellence Commission. Thank you so much for being with us today, Kathy.
Thank you, Angus, for having me.
So how we'll, a few just disclaimers up front. So I guess today it's a general information session responding to the questions that you ask. We will do our best to answer them, but if we can't or don't have the information at hand or aren't the best experts to answer it, we'll try our best to refer you to who those people may be and where you can get that information. We'll open with a bit of an overview of some of the key topics and themes that we are getting to get the ball rolling and to maybe prompt some questions that you might have too. We'll focus first on preventing the spread or preventing COVID coming into your service or workplace. And then secondly, we'll talk about once it is in, if you are supporting someone that is COVID positive at work and that's a particular situation. We will make sure to get to the Q&A box and the chat box as well for the questions that you have that are coming up. But I can say that all of the questions I'll be asking are based on those that members have been raising consistently with us over the last couple of weeks. I should also say the information is sort of general in nature that you'll be getting, and it's accurate as of today, which is the 28th of January. Important if you're watching it later online. This is a fast evolving situation. Advice does change and health guidelines do change. So if you're looking at this after the 28th, just note that advice may be different. You can always contact us to check anything. Okie doke. Well, without further ado, that's a lot of me talking. Let's get started with our panel of guests today. So I'd like to start, if possible, if we're talking about, I guess, COVID preparedness and prevention to sort of stop outbreaks happening in services. If we focus on that first, and then we'll talk about what happens if, unfortunately, we do have COVID in our services. So from a prevention and preparedness kind of perspective, if it's okay with you, Kath, I'd love to just get what the latest sort of advice is from New South Wales Health for community organisations, NGOs and disability providers as to what you can do to really minimise that transmission in your workplaces.
Yeah, thanks, Angus. I mean, from a pure infection prevention and control perspective, it's really important that you have COVID safe plans. So you have plans around, you know, what it might look like in terms of management, your baseline infection prevention and control, education and training needs to be up to date. It also needs to be practiced and rehearsed. So, you know, just doing it once is often not enough, especially if you've done it in anticipation and that was done last year and you're yet to see a case. It's important that you practice those. So education, training, making sure that you've got standard transmission-based precautions up to scratch. You're fully across the availability of PPE, how to use it, how to apply it, how to acknowledge and recognise that there's a case. I guess, you know, how you'd prevent further transmission. So it's really around that planning, education and training and really rehearsing those things before you get to that point. The other big thing is understanding your environment, particularly with COVID. You know, understand whether you've got a well-ventilated environment, how you can improve ventilation, what other things that you might be able to do to, you know, promote sort of air exchange, which increases the ventilation and turnover of air. So understanding those kind of things for ventilation and also cleaning your environment as well. That's kind of 101 very quickly.
Thanks, Kathy. And what has changed, if anything, in relation to Omicron versus previous variants? I mean, I just know anecdotally at the beginning of the pandemic, there was, you know, lots of talk about hand sanitizer and surfaces, and now it seems to be a very big focus on masks. And has there been a shift, or is it just, anything different?
Yeah, look, you know, with Omicron or any variant, and we're definitely going, you know, it's likely that we'll see additional variants. And whilst this evolves, Currently, what we're seeing is that the mode and mechanism of spread is unchanged. But because Omicron is far more transmissible, people often align that with its spread in a different way. And then you get a lot of non-health and other agencies that start to contribute to the discussion, and you get a difference in language, how we kind of assign things. Now, under health, and particularly when we look at infection prevention and the mode of transmission, COVID, regardless of whether it's the wild strain, which is our original Wuhan, the Delta or the Omicron, the mode and mechanism is still that it is transmitted through respiratory droplets, smaller particles, which are aerosols, and that's always been the case. Any respiratory-borne infection can be spread through aerosols if you create an environment for that to occur. There is direct physical contact with an infected individual and indirect contact through contaminated surfaces. So, I've got COVID, I sneeze, so I expel droplets, it drops onto a surface, it sits there, someone else can come along and potentially contaminate themselves. What we're seeing, though, is that it's probably, it's more likely that direct sort of contact around sort of expelling droplets rather than on surfaces. And that's why there's possibly more of a focus on masks.
Fantastic. Thanks very much, Kathy. I might ask Melissa now from the NDIS Commission. So that's great sort of advice from health as to what should be in place to prevent COVID spreading in our workplaces. But from the NDIS Commission, so that there's to regulate and support quality and safe services in the NDIS, what is sort of your expectation of disability providers in this context, and what supports have you made available to the workforce or their employer?
Yeah, thanks, Angus. Kathy's information is really important, and I think it's useful for everyone listening to know that as a regulator of NDIS supports and services, we're heavily guided by the health advice as to what is an appropriate response or what is an appropriate consideration in terms of planning. So in terms of obligations for NDIS providers and workers, all providers are covered by the NDIS Code of Conduct. And that's a really important tool for setting out expectations for, amongst other things, ensuring that people who are providing supports and services to people with disability are doing so in a safe way. Providers who are registered have got some additional obligations that similarly relate to providing services in a safe environment, undertaking necessary risk assessments to ensure that provision of safe supports, and really importantly, obligations around the continuity of support for participants. And so the key expectations for providers from our perspective is the planning that providers will have undertaken before now, or certainly would be doing now if they're responding to changing circumstances, to plan for how they are going to maintain that continuity of service provision for the participants that they support. And that's particularly important if a provider is delivering critical supports that support a person to eat, to drink, in their personal hygiene or their mobility at home. We would expect that those sorts of plans for business continuity also include provisions for preventing an outbreak and then for managing in the event of an infection amongst a participant or workers. So that includes understanding and planning for the use of a wide range of infection control measures that Kathy referred to, including the use of PPE. In terms of resources to support providers, the Commission's developed a range of material over the course of the pandemic since early last year. So on our website, you would find guidance for providers around prevention and management of outbreaks, for expectations around that planning for business continuity and continuity of supports. We also include on our website links to resources that are developed by the Australian Government Department of Health. So if you don't find them directly on Health's website, you can find them on ours, and that includes training resources around the use of PPE and infection control training, which are really important for all providers and for workers. We publish information in an ongoing way to particularly to registered NDIS providers that include alerts. So if there is new information from Health where there are changes to the advice from the Commonwealth bodies such as ATAGI or the Health Principles Committee, we will issue an alert to providers so that they've got the most up-to-date information and pointing them to any new resources that are available. Now, anyone can subscribe to our alerts. You don't have to be a registered provider, although they do go to all registered providers. So you can find all of those alerts that we have published are all on our website in addition to those other resources. I guess it's also just relevant for me to note, I think, well, I'm not here to speak for the National Disability Insurance Agency. We work very closely with the NDIA. The NDIA have put a number of funded provisions in place to support providers, and that includes funding for cleaning in certain circumstances, for facilitating vaccination for participants and for workers. There's certain funding arrangements for rapid antigen testing purchase, and people might be aware that there's been quite a recent announcement confirming that NDIS participants with core funding in their plan can use their NDIS plans to purchase rapid antigen tests, notwithstanding some of the supply issues that are a challenge right across the country. So in short, there's a lot of material on our website. I know it's a bit frustrating to say go and have a look at the website, but we've been working really closely right across other parts of the Commonwealth, particularly with the Department of Health. And so the information that's there has been drawn directly from those sources where it relates to some of the health-related aspects of what providers should do. Our expectation is that providers are planning to deliver those services safely, maintain that continuity, and having proper regard to the health information that's available to guide them in the things that they really need to consider.
And when you say planning, and I know that Kathy mentioned that the importance of having plans, but also the education, training, practiced and rehearsed. I mean, I assume that the NDIS Commission wouldn't expect these plans to be sitting on a shelf where no one's seen them or knows the content of them. That the frontline workers that are supporting participants should be familiar with the plans too, and be across what the plan is.
Yeah, it's really important that those plans take proper account of the needs of the people with disability that are provider supports. They need to consider any particular individual needs of participants depending on the type of service that's being delivered, as well as, in some cases, if a provider is delivering supports or services in a setting that's going to include a number of people, such as support in an accommodation setting like a group home or a service where people are coming together, then they also need to plan for managing and delivering those services safely when people are together. We do expect that those plans incorporate consultation with the people who are affected by those plans, particularly participants, but also including staff. We know that the best plans are always informed by the views of people who are going to be using them, and that's really important. Our experience through COVID and issues identified through the Disability Royal Commission have helped to inform a set of new practice standards that we released in November last year. And there are specific new standards for NDIS providers around emergency and disaster management. And so those new standards and the quality indicators that sit with them have been developed very much informed by the experience out of the first 12 months of the pandemic and the feedback that we got directly from people with disability as well as providers around the things that are important to consider in that planning. They're very new standards. They were introduced late last year for existing registered providers. They came into effect last Monday on the 24th of January. So they've got some additional guidance for providers in relation to expectations for that planning.
Thanks, Melissa. And, you know, a lot of the people in this attending this session would work in the disability sector for NDIS providers, but also we have a lot of members that work in the community sector funded by predominantly the Department of Community and Justice in New South Wales and also some federal departments. So I might bring Sophie in now from DCJ. What's the department's sort of supports that you've made available for services that workers should know about in terms of prevention of transmission of the virus?
Thanks, Angus. Well, look, similarly, I guess it's the same sort of approach. We have a COVID-19 management and vaccination policy for service providers, which we've implemented, and service providers are expected to undertake risk assessments and develop COVID management plans along the lines of what colleagues on the panel have said, looking at specific situations. And informed by consultation with staff. So it's expected that frontline workers and staff would be informing those risk assessments and plans, as has been previously mentioned. To support the development of those, we've had a range of different webinars that we've put together. We had 7 webinars last year, and then just recently, in fact, as late as this morning, we completed the last of a series of 3 webinars, specifically looking at what does it mean now that we have Omicron, because even from December to January, as we know, the situation changed quite significantly. We also have a website. So our website, it's the COVID-19 section, the microsite of the Department of Communities and Justice website for service providers. We have the policy. We have a range of resources, including all the recordings of the webinars that we've held about prevention and the hierarchies of controls and the various controls that people would be using. We also include resources from peak organisations, and including we have links, I think, to the Australian Services Union and to health. I guess there's been a range of different COVID grants that have been available to the service provider sector, and certainly the service providers have been encouraged to access those grants. And we're encouraging our providers to use those to, if needed, to purchase any PPE and purchase any rapid antigen tests that might be needed, and also to use funding, DCJ funding, if that's needed as well. And we're, I guess, strongly encouraging there to be an open conversation about what's happening for every specific circumstance. And I know some of you on the webinar today will have already heard me say this, to contact your DCJ contract manager if there's any particular issues. There's also the range of payments. There's workforce contingency payments, there's emergency payments that we've offered as well. So there's a range of different funding available that's offered to providers to help, I guess, workers manage risks. Yeah.
And I think that's important because a lot of that information is available to providers who find out that there are different things they can apply for from the department, but not necessarily all of the workers are aware that there have been, I think just before Christmas, additional funding available that organisations could access for things like workforce contingencies and additional PPE or things like that. So it's important that our members know that support's there, because sometimes there's organisations themselves might not even be aware of it. So if your service does, you can tell them to contact their contract manager as well if they haven't been heard about this too. just in conscious of time, I think we might move because there's been quite a few questions coming in around some themes. And before I get to them, I want to sort of touch on COVID outbreaks in services. So we've got our plans in place, we've consulted on them, we've trained, we've rehearsed, we've got infection control down pat, and we've got the PPE and we know how to use it, but COVID gets into a workplace or a service, which is still going to be very likely in the current level of community transmission. What are some additional measures or supports that are available in this context? So I'll start with you, Kathy, in terms of in a high-risk environment, say a disability group home or a women's refuge or homelessness service, so a residential 24/7 kind of service. If a participant or a client is COVID positive, what sort of changes then in what you should do? Because obviously that person needs ongoing support. So for the workers supporting that person, what would be different to otherwise?
Yeah, look, I mean, if you get a positive case in an environment like that, it's really around that, isolation and containment. So what you're trying to do is prevent onward transmission. That's your primary goal. Now, the challenge with Omicron is that usually by the time you've got it in a setting like that, and because of its high transmissibility rate, sometimes, by the time you get to, isolating and containment, you need to look at it a little bit differently. So normally we'd isolate the single case, then we'd contact trace everyone else, and then we'd kind of ring fence and waiting to see what happens with onward transmission. What we're seeing in some of those sort of shared environments is if you get one case positive, very quickly other people in those same rooms are going to be positive, regardless, like the spread's already occurred by the time you've actually identified someone's positive. So it's really around adjusting those parameters, and rather than moving everybody around, it's kind of like, sit and contain, right? And then you make sure that you protect your staff by the fact that you've got PPE applied appropriately. And that should already be a baseline level now. Given New South Wales is in red alert, all of our staff, when they're attending patients, should be in a baseline level of PPE, right? And that will provide a layer of protection. And then the risk, obviously, depending on what you've done with those patients, the risk increases depending on or decreases depending on the layers of PPE that you've got on.
Can you explain to me, excuse my ignorance, what you define as baseline PPE? Is that a surgical mask, or is that an N95, or is that eye protection?
Yeah, so it's interesting because, there's a lot of terms floating around. Full PPE, which really doesn't mean anything much. So baseline PPE at the moment, based on the public health order, like everyone must be wearing a mask indoors. Right, so that's your baseline. So it's whatever your public health order is, right? On top of that, you've obviously got then standard precautions, right? And it's making sure that I've applied standard precautions appropriately. So if I know that I'm going into a setting and, my client continually coughs, sneezes, whatever, regardless of whether or not they've got COVID or anything else, standard precautions should tell me I need to protect myself from being exposed. Right, so that would be at least a surgical mask, protective eyewear, and then depending on how much, whether I add gowns and gloves. Right now, Obviously, then if I've got a known COVID positive, we are recommending for a known COVID positive the wearing of P2 N95s. So that's it's basically a face filtering respirator, or a high particulate respirator. So they filter down to sort of less than 0.1 of a micron. So they do provide additional layers of protection for aerosols, particularly when you're doing or involved in aerosol generating procedures or behaviours. But we are definitely seeing very good protection If I'm positive and I've got a mask on, then we're seeing good source control. And Angus, if I'm exposing you, but you've got a surgical mask on, we're also seeing good protection when you've got that double mask.
Okay, because, I want to just sort of follow up with the PPE thing, because we've had so many questions about the, because it has sort of spread very quickly over the summer. And as I was saying earlier, while a lot of services were, I guess, prepared and should have had plans ready, people hadn't actually supported someone yet in the pandemic with COVID, and now suddenly that's a lot more common. And we have had lots of members contacting us saying things like, I've just arrived on shift and the person I'm supporting is positive and there's only a surgical mask. What kind of PPE, should I be having or should I be asking? And it's interesting for Sophie and Melissa. Sometimes organisations at the moment have been struggling to get PPE. And so whether or not, setting aside whether or not they should have had stuff in there in the first place, what can organisations, through, would it be the NDIA, Melissa, for a disability, or DCJ directly for you, Sophie, where do people go to act if they're in a situation where they urgently need some PPE that they can't get?
Angus, people can contact the NDIS Commission, and in fact it's an obligation of registered providers that they notify the Commissioner of certain events and changes, including those as a result of COVID. So where there's an infection of a participant or a worker, or there's a significant impact on workforce in a provider's ability to deliver services. So say there's workforce shortages as a result of infections or people isolating, difficulties in accessing PPE or accessing rapid antigen tests. If anything that is an impact on a registered provider's ability to comply with their obligations and continue to deliver supports, providers must notify the Commissioner. It's really important that providers do that because we use it in a range of ways. One is if there is a critical risk for a participant through something like an inability to access PPE, we work closely with the NDIA. We refer that information to the NDIA, who can provide that assistance. Providers can contact the NDIA directly through their usual mechanisms, but if you make that notification to us, we will refer it at any rate, and it allows us to continue to be able to monitor the scale of the impact of the pandemic on people with disability, as well as service providers at a national level as well as at a state level. So it's really important to do that.
And Sophie, what about DCJ for the services that you fund and support? We're also hearing in community sector services that access to that PPE beyond a surgical mask is becoming an issue in some places where they're having outbreaks. So does the department assist?
We, as I said, in terms of access, we've provided on our website details of where PPE can be purchased and a list of suppliers. We've also encouraged providers to let, again, their relationship manager in DCJ know, or we've got a centralised mailbox as well to send to us if they need to access further supply. And of course, if they need to, they can use DCJ funding to purchase that. But we've got, and we send out regular emails, but they're usually with links to our website where PPE can be accessed.
Yeah. And Kathy, just to follow up to you, and I've seen a sort of a question like this in the chat too, that lots of the people who our members support, though, have other considerations that might make it difficult to do a sort of, isolate, put a mask on, etc. Once COVID's in. They might be young people, they might have psychosocial disabilities, they might have addictions or like various issues. So in those particular settings, I guess, is that about having the plans in place for that, or is there particular places you can get advice from health in those types of settings?
I mean, there's always escalation pathways, particularly when it comes to providing some additional help with infection prevention and control. So our own department at the Clinical Excellence Commission, who leads infection control for New South Wales, will offer support and has actually gone on site to help some of the group homes. And, you know, some of those, it really comes down to experience and understanding your environment. So in those kind of situations, you know, it'd be assessing that, and it'd be treating, for example, the home like a bubble, you know, and then adding, you know, external kind of areas to protect staff. So it's very difficult to say on a webinar, okay, we're just going to do 1, 2, 3, all right? Because it really depends on your clientele, what kind of environment, you know, is it a home? I mean, we've been on site and, you know, they had some beautiful group homes and the staff were eating meals with the clients, right? And that's a great idea to do. But when you're dealing with infections, it's how do we kind of break and separate those risks, right? And so for a period of time when you've got an outbreak, you might want to separate some of those things, add like separate toilets, you know, things like that. It really depends on the extent of the outbreak, how many cases, the vulnerability, you know, vaccinated or not vaccinated. But there's some of the things that you need to actually apply. We can also do kind of phone conversations and walk people through it, or we can do site visits as well.
Okay. And I guess and services would go through their local health district or to get that support in those settings, or would it be directly to the Clinical Excellence Commission? No,
they can go through their LHDs if they've got good connections with their LHDs. All of the LHDs have very strong infection prevention and control teams and services. It's probably one of the poorest resourced professions, and you know, we usually kind of all help each other out. So if the LHD can't do it, then they may refer it on to us to help. We've got a little bit more capacity, and I've got some additional ICPs that we were using for the quarantine system. We're now supporting the LHDs.
And just quickly to Melissa and Sophie, because I want to get to lots of the questions that we've had, but in that COVID positive environment, while you're going through some of those additional supports and controls that Kathy talked about, I do understand there is additional funding and support specifically in the case of COVID outbreaks. As I understand in the NDIS, there's a payment. I know this is for the NDIA, Melissa, but there are payments daily per participant that's positive, I understand, to support these additional mechanisms you need to put in. Is that right?
There are, and the NDIA publishes quite a lot of information on their website around the funding that's available to support that, and providers where they've got a contact with the NDIS should engage with them to get specific information that might be relevant to their circumstances if they've got queries.
And Sophie, in sort of services like intensive therapeutic care or SHS services, if there are outbreaks in a refuge or a resi, there are additional funding supports, aren't there? Is my understanding?
Right. That's right. There's emergency action. There's emergency payments that can be put forward, so they can be applied for and then distributed to providers in the ITC and SHS space. Yes.
Okay.
Yeah.
So let's get to some questions that have come in. So we've covered sort of prevention principles, some of the things around once COVID is in our services. Now, we haven't mentioned this much, but it's a big topic, rapid antigen tests. Okay, so we've got a few questions on that. One is, I guess, directly, you know, to you, Sophie, but which is around what's the government doing in terms of accessing for RATs to staff and clients in NGOs in New South Wales? What's being done? Because I think we hear a lot about schools getting them, and that's great. But is the government in New South Wales looking at community services, including also disability services?
Yeah, thanks, Angus. So Department of Communities and Justice, actually the Stronger Communities Cluster, is working very closely with New South Wales Health on obtaining supply of rapid antigen tests and distributing them. That's an ongoing discussion. We have a priority cohort where we have identified and managed to distribute rapid antigen tests through to residential providers of 24/7 services already. So we have already distributed 35,000 rapid antigen tests to that cohort. We're currently working with health to ascertain future supply and develop a distribution strategy, but we're still getting some data and clarity on what that might look like. But we're certainly aware of the need. We're talking to peaks, we're talking to providers, we're talking daily to health, our colleagues in health, about supply and distribution.
And I can see a question there around, which is probably for me, should workplaces supply them to their staff, or is this an expectation of the union? And I think in our previous session last week, we've talked about the fact that under workplace health and safety law, employers need to do all that is reasonably practicable to minimise the risks and put in place reasonable control measures. And rapid antigen tests certainly are a very important control measure. The problem is they're difficult to access. So in terms of what's reasonably practical, it might be difficult for providers to source them. But what we certainly are saying as the union is that they should be available freely and accessible for all workers and the people you support. That's been fairly consistent. And the one thing I would also remind people of is that for members, that in the award, any essential safety equipment or material must be paid for by your employer. So you shouldn't be expected to pay for them yourself at work. Just remember that. That's very explicit in the award. We have heard of members being expected to pay for their own rapid antigen test as a requirement of work, which would breach the award. Okie doke. Let's look at some other questions that are coming in. There are a lot on PPE, Kathy, so I'll put some to you.
Yeah, I'm going to theme some of that because I've kind of been looking at some of that. And look, there's a couple of things. Not all of our PPE are equal. And I get where you've said like a KN94 says that you can't, use it for asbestos. We are talking about completely different particle sizes. But again, a KN94 or a KN95 is not necessarily the same as an N95 or a P2. There are also access to surgical P2 N95s, which give a greater fluid resistance barrier rating. There are different levels of surgical masks, levels 1, 2, and 3, which will filter out different pressure particles for fluid. So they're definitely not all equal. And it's important. Now, if you're being supplied by the National Stockpile, they normally do their own risk assessment and validation. If you're being supplied by New South Wales Health, we have a very robust system in place. The biggest tool would be to source something that's TGA listed or registered. That's probably one of your biggest protective areas. I think in terms of like this idea of full PPE, break down your PPE. So COVID is spread through either contact, droplet or aerosols, which is aligned with airborne precautions for health. All right, so they're the precautions. So if I'm not having any contact, there's no reason to be in gowns and gloves. Right, so my primary PPE, especially if you've got absolutely no cases, right, your minimum would be a surgical mask with protective eyewear. Right, and protective eyewear is very important if your clients can't wear masks and you think that they might be the cases. Right, so that's that kind of thing with PPE. And if we reduce or scale back on some of that, given we're sitting in summer, there's a lot of staff sitting around in PPE that don't need to be sitting around in PPE.
Yeah, and we certainly have had a lot of inquiries that are new to the union around the wearing PPE and heat and exhaustion and the sort of side effects of that in the summer. And because a lot of the services our members work in, they're not like health services that are air conditioned, etc. So it can be raise its own issues. On that, in relation to ventilation, there was a question around air conditioners and the spread as in terms of ventilation.
Yeah. So what we're seeing with COVID particularly is that these aerosol particles or these droplets can either be large or small. And particularly with COVID is that we're seeing the ability of these smaller particles to kind of remain in the air for longer periods of time. So when we talk about ventilation, and it's hard to consider ventilation wearing a mask, but what we're talking about is what we're trying to do is make sure that in the environment we're in, we've got air exchange, right? So if you imagine every time a room changes the air fully, then it filters out or dilutes any infectious particles, right? Now, in hospitals, we set our rooms. So they have usually 8 air changes an hour for a normal room, up to 25 to 30 air changes an hour for, our negative pressure rooms and our operating suites, right? Now, average rooms with air conditioners usually sit around 4. They say that the evidence is saying that you need about 8 air changes an hour to kind of clear COVID. And that's what we're really trying to do. We're trying to dilute any stagnant air to get rid of the COVID particles so that it's not sitting around in the air. And that's where our non-health, colleagues talk about airborne, right? Because it sits in the air as smaller particles because the air change is not changed. So you can do simple things if you've got no air conditioning. It's about opening windows, right? Opening windows, even a slight amount, getting a cross breeze, that's going to actually change air conditioning and ventilation. If you're in a car, there's guidelines at the CC around how you improve ventilation in cars, making sure that you don't recirculate the air inside the car, but draw in outside air. So there's a few things that you need to do in those sorts of things. But it does definitely play a role, hence why outside, the recommendations is, do things outside as much as possible.
And there's also a question about fit testing, which I know someone's mentioned to me before. It's important that masks are fit tested. What does that mean?
Yeah, well, again, the requirement under the standards for applying a P2 N95 respirator is that they are required to be fit tested. Now, what that does is there's either qualitative or quantitative fit testing. So qualitative is it gives me an assessment that I get a seal, right? Quantitative actually measures how well I actually get that seal. Now, regardless of whether I fit test or not, right, that's not what's going to protect me when I put on a respirator. What protects me is every time I put one on that I've performed a fit check seal or a fit seal check, right? So that I put one on and I can actually, feel that I've got a seal and there's no air leaking. And look, pre-COVID, health has survived for around about 30 years implementing transmission-based precautions on educating, training with fit checking. Now, there is definitely, a need for fit testing. Is it at the level that we've applied across health? Possibly not. There's a lot of expense. It does not guarantee me when I actually put my respirator on that I get a seal if I don't fit check it. So in lower risk areas, we're definitely recommending educating and training for fit checking. And then if I'm not comfortable that I could get a seal, then we would recommend definitely for fit testing.
In light of the what Kathy sort of been talking about and some of those recommendations, there has been a question here, I guess, for both you, Melissa and Sophie, around are there expectations that staff are trained to know about these kinds of things? I mean, I think we talked a lot about having plans in place, but just to clarify again, lots of these things, I go back to what Kathy said at the opening, require the practice and rehearsal kind of stuff. So are there expectations that happens?
Yeah. Certainly from the NDIS Commission's perspective, yes, there is an expectation that workers would be appropriately trained and have refresher training or new training as the case may be around the use of PPE, how to use it properly, and when to use it, in accordance with any health guidance that might be in place from time to time. It's a condition of registration in particular for registered providers as part of their obligations under the standards to ensure that training.
Sophie?
To use PPE properly, I think you do need to have some training or information about how to put it on and apply it. So we do, again, on our website, have some video links about how to use PPE. And we're certainly also working at a local level with local health districts. I know some of our district colleagues are working to arrange some particular sessions so that there can be either live webinars or some recorded webinars about this is how you actually do fitting. So yes, there's an expectation that there's a level of knowledge and training about how to put on PPE properly.
So Angus, if I can just add,
Yeah.
so the Clinical Excellence Commission has made all of their COVID-19 resources publicly available, including our training videos, our respiratory protection program. I've put the link in the chat for everyone, and we've done that purposefully so that organisations and agencies that may not be well equipped with infection prevention and control, these things are really done for them, and we've tried to do it in a way that's considerate of the levels of people looking at them.
Mm. And there have been some also questions in particular around, I guess, restrictive practices and how that interplays with, say, positive, when there's a positive outbreak, you need to do certain things. And, you know, we understand in both the NDIS context, but also in community services, there are there's a whole other set of considerations around, you know, the rights of the people you're supporting. And so, I mean, that I imagine should be a part of the planning, training, rehearsing, practicing to have those things considered. Would that be, because they need to be taken into account, I assume, Melissa and Sophie?
Yeah, as part of that planning earlier, I was talking about a provider, needing to, to be cognizant of the needs of the participants they support in that planning, as well as workers. So if there are, if you have consumers of the service who have got support needs in relation to their behaviour, then planning how they're going to be safely supported through the course of, different stages of pandemic or infection or preventing infection is really important. We know that this is a challenge. We issued developed some guidance material last year for providers in relation to restrictive practice in respect of COVID, and that includes in relation to vaccines and other aspects of support provision. I'll have to dig out the link. If I can't find it while we're on the webinar, I'll forward it on to Angus so that can be available. It's important that providers continue to meet their obligations in terms of reporting if they are using restrictive practice where they don't have authorisation and it happens to have occurred in relation to some aspect of providing a service during COVID, or contact the Commission and talk to our staff to get advice about whether or not something does need to be reported so that we can monitor that.
Sophie?
I guess it comes down to the specific circumstances of each environment and operating environment and the client group. A 24/7 residential facility is quite different to a neighbourhood centre, for example, or a case managed service or drop-in. So it really, there is an expectation that any risk assessments and plans that are put in place, including use of restrictive practices or any of the control measures, are taking into account the specific needs of staff and clients in that particular circumstance. I mean, the bottom line is continuing as much as possible, obviously, to provide the continuation of service to clients, but to also protect staff and client safety. But it's very similar to Melissa. We also have a range of different material that we've developed as part of our guidance on our website. We have Justice Connect, who is also working with us, a not-for-profit law who can be contacted if there's any particular legal questions related to that. And they were participating in the webinars last year, which are recorded on our website. So, and again, also reach out to us if there's any particular questions or if there's any concerns about that. Yeah.
Okay, what I'm going to try to do now with 5 minutes to go is a bit of a rapid fire. I'm going to go through some of the questions I've got here, and anyone that thinks they can answer it, have a go, and that might include me, just to try to get through some of them. And some of them might be things we need to, it's about referring people to other places potentially to get the answer. So we've had a couple of questions from people who have tested positive, but it's been several weeks ago. So someone said once they've tested positive but recovered, do they then need to continually to get tested if they have symptoms within 28 days? Do we know any answer to that?
So the recommendations are, if you've recovered and don't have symptoms, then there's no need to be retested. The problem with retesting is that you may in fact continue to test positive, but that doesn't necessarily mean that you've got active disease, nor does it mean that you're communicable, i.e. you can spread it. So the recommendations are, day 7, if you are no longer symptomatic, then day 8 you can, basically go back to the community. In high-risk settings, the recommendations are you may need to take another 3 days to make sure that after day 10 you're definitely asymptomatic. Depends on the critical workforce requirements. There's a little bit of flexibility in that.
Okay. We've talked a lot about the PP. I'm just looking down to some of the other questions about time off. Can I change my annual leave to sick leave? Yes, you can. You can do that. I can answer that one. If you've used annual leave but you've got COVID, you can change it to sick leave. Talk to your employer about that. Workers cancel my shifts while I've been isolating. Can I get these back? It will depend on the type of isolation support your employer is providing. Contact the union and we'll see what we can do to help. Close contacts, how long should they be isolating for? 7 days is my understanding, and potentially longer if you're in a high-risk environment.
That's correct, Angus. So, there's been a lot of talk about, reducing the length of time for isolation. The reality is, regardless of what we do with timeframes, the incubation period for COVID is from 1 day to 14 days. What we are seeing, though, on average, especially with Omicron, is that it's usually around day 5 or day 6. Right? It's very rare to get beyond that. We still have some Delta circulating, though, which is often around that day 7.
Okay. And then we have a few around supporting COVID positive people still, which was around are providers expected to advise the other workers in that service if there's been a positive case? I guess this is a part of the DIY contact tracing at the moment. Is that an expectation of is that for the commission, for example? Like, would if there's a positive case, the provider's meant to be telling the other residents and all the workers?
Well, providers have still got to comply with privacy legislation, and certainly the commission doesn't expect that a provider would be breaching an individual's privacy, whether they're a participant or a worker, as to their health status. But if a provider is aware that someone that they support or someone that they employ has an infection, then there is an expectation that they're taking steps to deliver any support safely. So that would include how are they utilising PPE to continue to provide that support. What sorts of changes do they need to make to the way that support is delivered, perhaps, and how they consult with the participant who's affected or other participants who are affected in making changes to that support.
And I imagine it should be in their plans for if there is COVID in the workplace around the contact tracing they may need to do with to people that have come in contact during the infectious period. We've also had a question that's quite specific about as workers, we have a client that's positive. We keep getting conflicting information about if we have to notify the NDIS. I think it's pretty clear you do have to notify the NDIS Commission and the public health unit if you get a positive case in a disability service.
Yep, that's right. Providers can access an online web form on our website for making notification of changes and events in COVID. It's not a long or complicated form, but it is really important that you give us that information. We're not collecting identifying information, it's collecting statistics effectively.
And there's also been a question about boosters being mandatory, which I understand it's been announced that they will be for those workers who had 2 doses mandatory by the New South Wales government. I don't know, though, if the actual health orders have been put out yet, but I understand that is coming. So that would cover certainly the disability sector. Is that your understanding, Kathy?
Yeah, so they're currently rewriting and updating the public health order. Now, whether that makes this round of revision, they were concentrating on some other components, but yes, that'll come out. And I think they're looking at a national approach where you won't get a green tick unless you've got the boost, the 3 doses.
And we do know that vaccinations are a really important safety mechanism, and the boosters do make a really big difference. Okay, well, I promised that we'd be over by 3 o'clock, so I know there are still some questions and comments coming through, but the great thing is that Melissa, Sophie and Kathy have all put in the chat links to their organisations' websites which refer to additional slides, training, webinars, and I assume also direct contact information for the Commission, DCJ and the Clinical Excellence team if you have other questions. You can also send them through to us, your union, and we can assist you with advice too. Thank you so much, Melissa, Sophie and Kathy, for joining us this afternoon and responding to a lot of the issues that our members are concerned about today. We really thank you for taking the time out of your schedules to do that. And of course, I want to thank all of our members that joined us who are working in very difficult circumstances right now. I know that about 15% of our members in the last month have had the virus, and those who haven't have generally been working lots of overtime, additional shifts, and are pretty tired. So I want to thank all of our members for the work that you do every day, supporting our community, supporting vulnerable people. And thank you very much, everyone, for your attendance at the session. Have a good weekend. Thank you. Thanks again.